But for this afternoon, she will tell us about what are the tricks in luteal phase supplementation. Suling, please.
Yes, good afternoon, everyone, and thank you for being here. And I would like to thank the organizers for inviting me to give this lecture. Some parts of this lecture is still close to my heart. So we're talking about luteal phase supplementation and fresh and frozen cycles, and there's a lot to cover, so I have to go a little bit faster. So nothing to disclose very much. Okay, so this is my outline, and we will be doing the definition, rationale, IVF's fresh cycles, frozen cycles, individualization of support, and the conclusion. So yes, a moment for your polling question. Just to know whether you would understand some of the problems. Okay. So this question is on luteal phase deficiency in GnRH agonist triggered IVF fresh cycles. And what is the reason? It could be A, frequent stimulation of ovarian follicles, high doses of progesterone given, severely shortened luteal phase, and oocyte retrieval of multiple follicles. Voting done. Okay, so the answer is actually C, severely shortened luteal phase, although there's theoretical, there is some theoretical reason that oocyte retrieval of multiple follicles may also be a problem with luteal phase deficiency, but it's a deficiency in also other ACG triggered IVF fresh cycles. Okay, don't worry about it. Okay, so we go on to the definition. An LPD is defined as disorders resulting from an abnormal corpus luteum. And obviously, after the follicles have been stimulated, they have to be triggered, and there will be a lot of corpus luteum. But unfortunately, the hyperstimulated cycle and the normal cycle are different. Although the hormones are high, excessive, but they also fall very quickly. So this is mainly due to the negative feedback from excessive estrogens and progesterone from excessive ovarian stimulation to suppress the natural LH surge, which contributes to the functioning of the corpus luteum. The other theory is that, after egg retrieval, some of the granulosa cells have been removed, and that also can contribute to the LPD. Ultimately, LPD causes implantation failure and pregnancy loss. But most of the time, we do have pretty good pregnancy results, despite all this, right? So before we do actually understand about LPD, we need to know about the two methods of ovarian final egg maturation trigger. So there's two of them. One is the ACG trigger, and one is a GnRH agonist trigger. And number two is, I don't know where to put this, but I just wanted to also mention that if you need to have luteal phase support, you can do it from OR to the day 3 post-OR for fresh embryo transfer. And this is in the ASHRAE guidelines 2019. As you can see, the natural cycle, which is the red parts, and with the GnRH agonist and ACG, and is better than the one with the GnRH agonist trigger alone. In the Cochrane database 2015, luteal support, phase support for assisted reproduction cycles, and they have this Cochrane data comparing ACG with controls, that means no stimulate, no trigger at all. Sorry, this is support. HCG support with no support at all versus progesterone support on this side with placebo treatment, that means no support at all. And these are the old days in which you can do this. And you can see that HCG support in the luteal phase is similar to the progesterone support in the luteal phase because they both work very well. In the old days, I remember we just gave HCG support, 1,005 international units every 2 or 3 days. So it still works very well to support the luteal phase. So this is HCG support, it's not HCG trigger, okay? So in a fresh cycle using HCG trigger, the HCG support also stimulates the corpus luteum to produce progesterone and other hormones that mimic the LH surge. And they can protect the luteal phase for the first week after the embryo transfer. So after the embryo transfer, if the patient is pregnant, the pregnant HCG itself can support itself through the corpus luteum. Unfortunately, there is an increased risk of ovarian hyperstimulation syndrome. Hence, HCG at this point in time from the ASHRAE guidelines is not recommended as a major luteal support. And this is just to show you the OHSS. The lack of OHSS is favored with progesterone, and more OHSS is in the HCG regimes. And these are all the luteal support that I can come across. And there are lots of luteal supports, including all the different types of progesterone, whether it's intramuscular, subcutaneous, vaginal, micronized, pessaries, and oral dydrogesterone. Okay, so every center has their own favorite. So it's like your phone. You prefer a Samsung, you prefer an Apple, you prefer anything else, as long as it works. HCG is concerned, we already talked about that, and we do not now give HCG for HCG-triggered fresh cycles. How about estrogen? Estrogen, again, in the studies, does not seem to be a much difference between estrogen plus progesterone support compared to progesterone support alone. And there are some other research hormones that have been used, recombinant LH, under research. Obviously, it's very expensive. And GnRH agonists in single or bolus doses in the luteal phase. So if you've not heard about that, you can have a look at it. Apparently, it works quite well. But again, it is under research. So they compared all the different various methods of progesterone, vaginal versus oral, vaginal versus rectal, all kinds of modalities. And the conclusion is there was no difference amongst all different modalities of treatment. So you're welcome to use anything for this support. Okay, so but the support is necessary still. So for those who are only doing freeze all, you can forget about all these next few slides, because now we are talking about luteal support in GnRH agonist triggered fresh IVF cycles. So in the agonist triggered IVF cycles, there is severe suppression of the corpus luteum and an very extremely shortened luteal phase. And you could not support it from all the examples and Professor Humaiden's experiences. You cannot support it just by progesterone alone or even estrogen alone. You need to have high doses of intermuscular progesterone, estradiol, to be able to support this kind of luteal phase. So in this kind of luteal phase, there are a few examples that you can do. HCG small doses, combination with GnRH agonists as dual trigger, agonist plus HCG, or intensive luteal support, as I mentioned, with intramuscular progesterone and estrogens. So on this panel, I think Professor Humaiden has actually suggested that there may be some of these patients who can get away from the OHSS by just giving them 1,500 international units of recombinant ACG at OR day, and then 1,000 at OPU plus 5 plus vaginal progesterone gel. And if they are less than 14 follicles, and if there's in the middle 15 to 25 follicles, then you can give 1,500 international units of recombinant ACG and OPU and vaginal progesterone gel, or freeze all. And if you have the extreme circumstance in which you have more than 26 follicles, then is freeze all. Okay. Okay, so I came across this interesting ICE trial by Santos Ribeiro, and it was published in Human Reproduction 2020. And there were only about 212 patients. It's a randomized control study in which if you were a high responder, you were randomized to the ACG plus estradiol and progesterone, or you had freeze all. So, and you can see that the results were pretty good. On the top panel, the results of the fresh transfer was 48.6% for clinical pregnancies and live birth 39.4%. There was no statistical significance, although it did look like it's slightly slower. Unfortunately, in this ICE trial, there were 9 women with moderate to severe OHSS. So I think it dampened the whole problem of the ICE trial, although it can be done, but again, there's this problem of OHSS. So we've taken that Professor Humaiden's theory, and we actually modified it a bit, because with 1,500 international units of HCG, we also had OHSS. So for our patients, maybe they are smaller or maybe they're more sensitive. We went and gave them 1,000 international units at OR plus progesterone only. We don't even give them estrogen. And then if there are more than 20 follicles or the estradiol was 20,000, or patient was at high risk for OHSS. But of course, we still do freeze all when there were more than 30 oocytes collected or patient asymptomatic post-GnRH agonist trigger. So for example, in 2016 to 2017, this is just a comparative study to show that the women with the Luteal HCG support after agonist trigger, we had a 45.5% clinical pregnancy and 33% of live births. There was one OHSS patient, and I went back to look at the history. She was not even admitted, and she just had some bloating, and I'm quite sure it was not really a very severe case. And for the FET column, those who had freeze all, we looked at their results, and we had 30.4% clinical pregnancies and 24% of live births. Obviously, no OHSS. Yes. So to us, we could have saved some of these patients who did not want to go for the freeze all. We could still push it a little bit more. And so far, we have been doing this, and we have quite good results, and hardly any OHSS. The OHSS we have gotten was when we gave ACG trigger for those we didn't think that they were going to be a high responder, but they managed to get OHSS instead. Okay, so okay, we are good in timing. So now we look at the luteal support, because those who do freeze all, they don't need to know about the part that I was talking about. So now, if you do freeze all the embryos, it's very important that you have a very good luteal support for your frozen embryo transfer cycle. So there are many ways that you can prepare the endometrium for the embryo transfer. And you can see that these are the ways that you can. And the timing is important too. The timing when to replace your embryos. But apparently, for example, in the top column there, fresh embryo transfer and artificial embryo transfer, you can actually put embryos back in a day's difference, whether it's cleavage or blastocyst or day 5. And it seems to have similar kind of results, but I don't have time to show you those results. So you can do natural cycle, you can do artificial cycle, or you can do a modified natural cycle. Okay, so there is this, this theory that natural cycle is still the best for various reasons, because the corpus luteum can produce other substances that may be important for implantation, and there's few medical intervention. It's much easier. And post-delivery wise, there were lower risks of adverse perinatal outcomes, lower maternal complications like preeclampsia, and some studies show better pregnancy results with LH surge when they measure LH surge compared to the HCG trigger. The drawbacks is that ovulating women is very difficult to chase after, and we only operate on certain days. We have public holidays, we have Sundays, yes, and we do need close monitoring, scans, blood tests, urine tests. There's no consensus on the LH surge detection. There's so many different ways of doing this, whether you're doing urinary LH or you're doing blood LH, right? And but however, if you do a modified natural cycle, you could trigger by HCG, and then you can calculate when to do the transfer. However, with those who have had a corpus luteum, there are some small studies that show that they still need progesterone support. So even after you're triggering, we still do give patients progesterone support, as in this graph. Okay, so artificial hormones for frozen embryo transfer. So which means that you actually replace and you become the ovaries for the patient. You place and you support the endometrium. So you could do with or without downregulation with GnRH agonist. And you have to give estrogen, oral, transdermal for the first roughly 14 days. Then you scan for the endometrial thickness. Some people use 7, some people use 8. And then you give them progesterone, intramuscular, subcutaneous, oral, vaginal, rectal, added to the estrogen. And you calculate the date of the embryo transfer from the start of the progesterone and mimic the natural cycle hormones, but there is no corpus luteum. But you need to support this pregnancy if the patient is pregnant till the luteal placental shift. Cannot stop just after pregnancy because there's no corpus luteum. So that's about 7 to 10 weeks. And we find it easier to schedule by prolonging the estradiol phase before you start the progesterone phase. Then we can calculate backwards to from the transfer. Okay, so meta-analysis wise, there is no much difference comparing artificial cycles, natural cycles, mildly stimulated cycles with clomid, letrozole. No difference in live birth, clinical pregnancy, miscarriages. If you use aspirin, sildenafil, there's low quality evidence and none for addition of steroids. Okay, so these are all the evidence that in the Cochrane database, in the database meta-analysis. Okay, so I have, oh yes, I'm good timing. So now I have to give some time to the individualization of the luteal support in frozen embryo transfers. So I'm mainly talking about the artificial cycle. So we thought that, after the transfer, I would tell the woman or the couple, okay, whatever happens is between the embryo and the uterus. We have done our part. You just make sure you take your hormones, but maybe it's not so. So some studies have shown that there is the lower quartile of the serum luteal phase progesterone in women who have gone through the artificial stimulation have a lower pregnancy rate or live birth rate. Okay, and rescue can be used. So we still need to intervene, and some Labrata, Lan, Alvarez et al. Have published papers to show that they have used subcutaneous progesterone with vaginal progesterone, intramuscular progesterone with or without vaginal progesterone, and vaginal progesterone with dydrogesterone. So in the interest of time, I will show you mainly Lan's paper. Okay, so Lan's paper in 2021. So this is not a randomized control study. This is a cohort study, unfortunately. All the other studies are not randomized either. So she had one group that went on progesterone only, and this is an estrogen. This is artificial cycle. Another group in another timeline went on progesterone, estrogen, and dydrogesterone. And they discovered that the lowest quartile of progesterone levels, and this is the progesterone level that was done on the day of the embryo transfer, was almost significant in a matter of live births, in ongoing pregnancy, but not significant in the live births. But what was interesting with the group that had dydrogesterone, in addition, there was a significant decrease in the miscarriage rate. Okay, so maybe there is something there. The other authors have also discovered, but again, it's not randomized control studies. With the intramuscular or subcutaneous progesterone, they have also discovered that there was lower live birth rate with women who have a the lowest quartile of the progesterone levels. And after they have been supported, they discovered that this was neutralized. So maybe we have something that we can do for the frozen embryo transfer patients. So in the conclusion, for the first part, we must all agree that all control ovarian stimulation cycles should be supported to prevent LPD, although individual variations exist. There may be some patients who don't have LPD, but the numbers are few. Progesterone in all forms is the main luteal support for HCG-triggered IVF fresh cycles for a fresh embryo transfer. HCG support is discouraged. It is still possible to perform fresh embryo transfer with careful selection of patients with small doses of HCG rescue of luteal phase after GnRH is triggered. OHSS should be avoided, and the ASHRAE 2019 guidelines says freeze-all is still the safest, of course. So in conclusion, for the frozen embryo transfer cycle, most experts still believe that natural cycle is best, but because of many constraints that we have, maybe we can actually think about using the modified HCG trigger, which is easier to control. And we still need a luteal support with progesterone. For artificial frozen and hormone replacement, frozen embryo transfer cycles, obviously, for those who are anovulatory, you have no choice. For scheduling, yes. For lab constraints, we also do that. But there's a much more prolonged treatment, and you have to treat them till the luteal placenta shift. Progesterone measurement and extra support, it may help to individualize some of our patients that have very good embryos, and yet they get miscarriages or they don't get pregnant. Maybe there's something to do with their progesterone level. We really don't know why. And that might help individualize extra luteal phase support and improve their pregnancy rates. Thank you.